I'm Chris Banek. I'm an assistant professor at the University of Arizona, and I'm a PKD researcher. I come in as a cardiovascular and neurophysiologist. So I have always studied salt-sensitive hypertension. And I got to notice a lot of overlapping mechanisms between the model that we were using, the Doka-Salt model of hypertension, and PKD, both AR-PKD as well as AD-PKD. In both PKD forms, they present with hypertension, severe renal inflammation, fibrosis, as well as constant lower flank pain. Now, in the context of hypertension, we see this all the time, and that we have a very neat intervention known as renal denervation. I thought that treatment would be effective. So I called some colleagues in the field, because this is not my area, and I tried to find a good model. And so I found a good rat model. We got it in. We did our procedure. We lowered blood pressure. We lowered the renal inflammation. And we lowered, or I guess interrupted, the sensory nerve activity. And so what was really neat about that is it supported our hypothesis. But there was a very interesting finding that was not anticipated at all, is that renal denervation abated, or at least, attenuated the cystic progression in that model. So it seemed to, in fact, highlight a new method, a new modality to expand this very severely limited toolbox in effective treatments for PKD. And so that's where we are right now, trying to find out what the mechanisms are in mediating the aberrant nerve activity at the kidney level, and to see at what time is most effective in performing that renal nerve ablation and in achieving its maximum success. The most valuable commodity that we can give these patients is indeed time. And so I anticipate that our studies will show that we can at least attenuate the progression of this disease, permitting more time for those patients that are waiting for a kidney transplant, and maybe not necessarily having to go on dialysis as quickly as they would have if that were not available. I hope to recruit others into the field that are probably a little smarter and more inventive than I am, and allow just more investigation to expand that limited toolbox. The foundation level, the private level connection between the researcher and the foundation bridges a very, very important gap between research and the clinical side, at least the patient level. And nowhere do the other, I guess, sources of funding or funding sources, there's no connection there to the patient. It's just pool of money, and I submit it to other researchers that review that, and then they dish that money out. There's no context here. Whereas the PKD Foundation really gives it a personalized, very real connection